Hey, Dr. Hicks, thank you for sending over this case for us to review and take a closer look at. This is a mid to late 20s-year-old female. She has pretty severe TMD and migraines that she's had for most of her life, especially post-ortho. Not surprising, we tend to see that from time to time, but at first glance, when you look at the aesthetics, things look really good. Uh, One might argue that her upper molars could use some tipping, but without any specific need to do so, I don't think that necessarily indicates a poor outcome. The midlines are coincident. She has minimal recession. That might have been a result of prematurities either before or during ortho. But really, things look pretty good until you really start to unravel all of the layers of this complex case. I think she has a pretty bad case of what we can call the multiple bite situation. Spear used to call these cases dual bite cases. I don't think this patient knows where she wants to contact, and I think that's why her muscles are so angry and why her TMD is the way it is. But let's take a closer look at her nose. You can see it deviates to the patient's left quite considerably. Again, if you put a frame around that smile, you would say that's close to perfection. But then you look at the nose and you say, well, is there more to the story here? And as we start to take a closer look, we're definitely going to get a sense of that. You can see that her head posture is canted to one side. She's rotated. We're going to see the base of not the base of her skull, but actually her upper spine is rotated in relation to her head, which typically just means that her posture is out of balance. But again, her bite looks good here, but then if we take a look here, you can see she has a very significant overjet. I don't see that same overjet here, and I just don't think that's the same bite. I think these two are potentially the same, and I would think that this one here and this one here are the same. So it's possible she has two bites. What I think is going on is she's a skeletally class 2 patient. You can tell by the very obtuse nasolabial angle. I can't articulate the exact angles, but I can tell you that patients who are class 2 tend to have a very flat angle there. Reason being that the jaw and the skin around the jaw is pulling backwards, thereby decreasing this angle, especially during growth. And she just looks class 2. When we look at the CAT scan, we'll get a really good sense of the fact that she is indeed skeletally class 2. The orthodontist who fixed this case luckily didn't remove any premolars to try to solve this, which, we're both fans of, not removing teeth to try to solve malocclusions. There's other ways to solve these problems, especially if we can get involved with the patient earlier in craniofacial development. But it's clear that probably her centric relation is kind of distalized here. My guess is when we look at the CAT scan that she was in this position because the condyle was seated far back. But then she has this position where she comes forward and everything lines up. That's probably where the orthodontist treated her to. The problem is some patients, in order to get that nice bite coming forward, their muscles have to work extra hard to get there. We know that muscle activity, when minimized, drastically decreases TMD symptoms. Not for everybody. Yes, it's more complex than that simple statement, but we can definitely start to put the pieces of the puzzle together here and state that she probably has two different bites, if not more, and this discrepancy between the two is causing her TMD symptoms. I will also say that this overjet here is unlikely causing the occlusal markings that we see here. When you had sent me the email, you made the astute observation that she's only biting in the front and she's really not contacting out back. that is true in this bite. I think we need to get her back and really get an assessment of her different bites. I bet if you had her retrude and try to bite on her back teeth, that you would probably only see the second molars and maybe the first molars coming in contact, or just the posterior teeth. The point being that I bet her bite is different in this position. So a lot going on here. Where my observations came from, I was trying to make sense of this occlusion here and these occlusal contact points, because I was thinking it's possible, and we've seen it, where orthodontic retainers, fixed retainers, will actually distalize the mandible, but it's a very small movement. This doesn't look small to me. So that's where my attention started, kind of zeroing in on what her bite might be. Midline coincident here, midlines are not coincident here. I'm not sure if I already said that, but that's clearly different. So we have a lot going on. Let's take a look at nasal breathing. Nasal breathing is more often than not a component to TMD and malocclusion issues, if not in most humans in today's society. So we never want to leave that stone unturned, especially in a TMD case. It's very clear that the patient has nasal collapse. There's no way the air is flowing through that nostril. It's super important to know that if this restriction exists, it doesn't matter how big the airway is past that. In the world of mandibular advancement devices and OSA, obstructive sleep apnea, we tend to focus on the oropharynx and the lower airway, when in reality that doesn't really matter if the upper airway, especially the nasal valve, is collapsed. So we have to start here. So when I do my analyses now on the CAT scan, I start as far forward as I can, and I'm thankful that you had the assistant take 2 CAT scans, one for the lower, and then we got to evaluate the upper with really nice clarity. So good call there. As we go from the exterior nasal valve, it's important to know that there are 2 nasal valves: the exterior, which is the outer rim of the ala, the nose, and then the inner nasal valve is maybe 10 to 15 to 20 millimeters past that. When we if you feel in your nose a little bump there at the top of the ala, that's the interior nasal valve. The exterior is the circle that's created if you take your finger and put it on your nose. So there's 2 nasal valves there that are important. She most likely has collapse of both. The reason I bring this up, it's good to know which valve might be compromised, because the Breathe Right strip does a better job at handling the inner valve or the interior valve, whereas the mutes do a better job at handling the exterior valve. That's my observation, and one reason why I really feel, for me, one works better than the other, where other patients say the opposite. So treating this patient with the Nicade nasal airway triage protocol, sorry, I had a hard time thinking of that, would be great to get her started as she starts the journey to try to find an ENT. When you see nasal, the turbinates, these are the turbinates touching the medial wall, that's an obstruction. There should always be space in between the 2. So as we go posteriorly in the nasal cavity, we start to see the maxillary sinuses. From this view look good. And then we see the inferior turbinate. And the inferior turbinate is what shows up first. Here's the middle and then the superior. We'll start to see these better as we advance posteriorly in a moment. I just wanted to talk a little bit about what the turbinate's function is. I don't think the ENT world knew that the turbinates provided a lot of function. And they used to, in cases like this, reduce or remove the turbinates, a turbinate reduction, in an effort to increase the airflow. yes, airflow would increase, but then you would lose the function of the turbinate. The turbinate is a very important structure. As with most structures on our body, there is a function associated with that. Function follows form. If you reduce the form, you lose the function. In this case here, this patient has a lot of soft tissue, making the airway very thin. That tissue thickens when we're sick, when we have allergies, and then if there are certain conditions like concha bullosa, where these are large for whatever reason. Rather than reducing the entire thing, they cut it off right here and just take that whole piece out. The ENTs are starting to use radiofrequency techniques where they go in and reduce the submucosa of the turbinate, thereby leaving the surface and the function of the entity itself, thereby increasing the airflow. You can do this by using Flonase and other sprays to help thin that, but at the end of the day, those are pharmacotherapy techniques that over the long run might be unadvisable. So as the patient sees the ENT, I'm very curious to see what they decide to do here. That's not our area of expertise, but we should know what to look for. What's interesting is the patient's septum is to the right. Her nose went to the left. So it's almost like she has this curve to it. And then we start to see the middle turbinate. I can't make out the superior. I'll have to go to the text and try to see if I can learn more about where the superior is. But the inferior is the larger one. It's the one that the airflow sees first, and the one that I think most ENTs are going to treat. What is the ideal thickness of this zone here? I'm still trying to find literature that says that. There's all kinds of opinions on this. What I will say is if it's touching, if this turbinate's touching anything else, then it's causing an obstruction. Quick little comment here. This is the maxillary sinus sitting above, I believe, tooth 14 and 15, and we see a thickening of the Schneiderian membrane. It's important to kind of take note of these and try to make sense of what it might be. So if I take the crosshair and I put it over the entity, I look over here and I can see a side view or a sagittal view of this nasal thickening. I don't think these are polyps. Reason being, they look like they're reactionary to something to do with the teeth, in great part because they're symmetrical over the teeth. Oftentimes we see that with infection. I don't think this patient has infection. Her mouth looks, from a hygiene perspective, very impeccable. I wouldn't be surprised if this is caused from occlusal trauma. You can imagine if the patient's biting on this area, and she is in the CAT scan, she's definitely contacting here, that hyperocclusion can irritate the sinus membrane and cause inflammation. I have no literature to back that up, but I have seen through occlusal changes improvements in the Schneiderian membrane, just like we see when we do an endo on a tooth that is infected. She seems far too clean in the mouth to think that this is anything other than a mechanical process. With that said, definitely want to have the ENT look at that. While we're here, it's unrelated to this conversation, but when we do sinus surgery, we always want to look for the ostium, or the osteomeatal complex, or the infundibulum. Those are all terms to describe this passageway here. We never want to do sinus surgery in a situation where the cilia sitting in the membrane can't bring mucus and have it drain into the back of the throat. Interesting thing I read recently, we ingest about 4 liters of mucus a day. We don't do that if this is blocked. So you can imagine how much mucus can build up here. We see CAT scans where this is completely obtunded. Well, I wouldn't say obtunded, but filled, most likely due to obtunding of the osteomeatal complex. What we used to do back in the day when we did sinus surgeries is we'd send this patient to the ENT and say, can you please confirm a patent ostium so that we can move forward with sinus surgery. But now that we have this technology, it's pretty easy for us to take a look and see. In this case here, she has a very good situation going on as far as her draining. As I'm looking here, I started to see this little entity, and I can't articulate whether that's something concerning or not. Whenever I see something odd that my eye catches very easily, I look to the other side and see if there's something corresponding there. I would take some screenshots and just send this to the ENT and say, please comment on this here. It's very possible that that's just a normal polyp. With that said, I'm seeing a loss of cortication of the bone adjacent to it. So it's not something I would necessarily tell the patient to lose any sleep over. I probably wouldn't even tell the patient. I would just tell the ENT to have them address it. All right. Now let's go to the joint. Looks like my screen is freezing here. Now let's take a look at her TMJ. So if you go over and you click right here, you get a sense where the slices are. The computer will try to find the condyle for you so that you can get a sense of the joint. This isn't the joint, so you typically have to do the following. I take this line right here and I scroll up and down until I see the condyle, which is right here. If you scroll up and down fast, you get a better sense of it. All right, so I see the two condyles. Then I take this box here. You have to select that middle orange line, and then I superimpose it right over the condyle. And do that for both sides. Here's your condyle, and then I'll zoom in, holding down Control and going up. Control, click, and up. And here we have the coronal view, here we have the sagittal view, and the axial view. So, first thing I'm looking for, let's start with the right condyle, is just the general location within the capsule compartment. I also try to look for the disc itself. It's true that you can't locate the disc without an MRI, but you can sometimes just make a sense of where it is. I really do think that this is the disc here and here. I think she's very much kind of trapped backwards when she took this. It would be interesting to go and see what her occlusion looked like, to see if her anterior teeth were in more of that retruded position. So let's see if we can make sense of that, maybe going to the 3D volume render. I won't be able to tell on the anterior teeth, but if I look on the patient's right, she's end on. If I go to the side view, here the patient was that looks more like she was forward. So this is the patient's right. She doesn't look so end on here, which would tell me that she's in that retruded position. So what I'm trying to do is get an assessment of where her condyle is in relation to her teeth. Yeah, I'd really like to discern that. Let's go to her other CAT scan so that we can see the overjet. All right, so while that's loading, let's go back here, back to the TMJ. So I'm looking at the general position of the condyle, and after you look at enough joint spaces, you get a sense of whether or not that's normal. I would say that's abnormal. I think she's very superior in the compartment. We tend to like to see the condyle farther down on the eminentia here. Also, I'm looking at the disc space here, and that also looks very thin. When you look at this view here, really any view of the condyle, you're looking for what are called osteophytic changes or subchondral cysts. Essentially, they're radiolucencies just underneath the cortical border of the superior part of the condyle, of the mandible. Oftentimes, you'll see loss of cortication. All of these are signs of inflammation in the joint. It's super important to recall that presence of inflammation in the joint without symptoms isn't necessarily bad, and symptoms without inflammation isn't necessarily good or bad. Let me rephrase it this way. We can't draw conclusions when we see inflammation on the CAT scan. It's all part of a multifactorial set of observations that tell us what's going on inside the joint. With that said, if a patient has symptoms and they have degradation or active osteophytic changes, I'm going to be more aggressive with treatment. This all came from Jeff Okeson, and there's definitely a lot to understand there, that sometimes symptoms are not necessarily where they line up with what we see on the CAT scan. So if you're thoroughly confused, I've done my job. But we're looking for these changes here. And what's good, when we see this, we can submit to their medical insurance with a very specific diagnosis, osteoarthritis of the TMJ, send them a screenshot and say, based on the presence of osteophytic changes, subchondral cysts, we need to do XYZ. And typically what we do is we create a splint or an orthotic to get the condyle down and forward. The reason why most splints work for TMJ is because they pull the condyle away from the inflamed tissue sitting in the TMJ compartment. But you definitely see a kind of irregularity. That's not a dome shape at all to the condyle. Right there, very significant subchondral cysts. Flattening of the condyle. These are all signs of either historic or active arthritis. Interestingly enough, ear canal here. This is the sphenoid bone. What you have running through this posterior compartment is the chordotympani nerve, which when there's inflamed tissue and it pinches that nerve, the patient can have a ringing in the ear or tinnitus. So tinnitus is often associated with TMD. The treatment is all the same. Let's get the condyle where it needs to be, down and forward, which also happens to be a more neuromuscularly balanced position. It also tends to be an airway favorable position. So you can see how all of these things kind of coincide. It's very seldom that when you try to treat one thing, you're going to hurt another. They tend to all want to be down and forward to some degree. Let's go back to that other CAT scan. What I wanted to see here was the relationship between her anterior occlusion and the condyle. Unfortunately, we can't see the condyle here. It takes a very good scan to capture the condyle, the base of the chin, capture much of the sinuses and the nasal airway. Our CAT scan is capable of doing it, but it requires a technician or a doctor that knows how to do it. But as you can see here, her molars are a little bit different here. It looks like she's end on here. Go back here. Her mandible actually seems, yeah, it's really hard to tell. It would be super helpful if we had a scan that captured everything all at once. I really want to see the relationship of the front teeth and the position of the condyle. Nevertheless, I think the condyle is distally placed, and we need to get her down and forward. So let's go back here. TMJ. All right, so that's the TMJ analysis from a 10,000 foot view. I definitely think that there's pathology inside of her joint. It's very possible her migraines are emanating from this. She probably has pain coming both from her joint and muscle issues. The first thing we want to do is give the patient an aqualizer. We used to think the aqualizer caused exacerbation of pain if the problem was intracapsular. The rationale set forth by Spear was that the aqualizer would turn off the elevator muscles and allow the condyle to seat further. But in reality, when you give the aqualizer, you actually give the muscles the freedom to put the condyle where it wants. It will actually often decompress. So if you give the aqualizer and the patient has an increase in pain, make sure to find out where it is, and that information often helps us to come up with a more detailed diagnosis. But I would venture to say that all TMD, giving the patient the aqualizer as a first-line defense and the nasal triage protocol would definitely be something to get your patients out of the gates and potentially get them some relief while you come up with a more detailed plan. And if you want, see our NECADE flowchart on how we handle TMD cases. So you have a really good case here. I would let's get her back so we can take a look at her together. Please take a look at the patient information essay on TMD that I sent you a while back, actually last week. The patient is to pay a $1,200 fee for the full TMD workup. We also want to get her with Ray to get a sleep analysis. This is a case we want to leave no stone unturned. Get her on the nasal protocol, and we can go from there. So hopefully this at least provides some context on how complex these cases can be. This is definitely one of those cases, had you tried to just do Invisalign and not treat the nasal passage, that you probably would have exacerbated her symptoms. We really don't want to do Invisalign until we find out where her mandible needs to be, and then we're going to figure out how to get there. I wouldn't rule out surgery for this patient. If she doesn't want to, we can cross that bridge when we get there. My guess is that we can get everything comfortable and then get her on a very equilibrated bite where she has a mild overjet and her mandible is coming into contact with her maxilla in a neuromuscularly balanced position. It probably won't look as ideal as where she is now, but at the end of the day, it'll still look great, and she should be much more comfortable. We'll get there through the use of the almost day and nighttime appliance, but I'm jumping the gun a little bit. We got to get diagnosis first. I also would encourage you to have her get her medical card so that we can start the process of trying to bill this to medical. I don't have a whole lot of experience submitting this to medical. With that said, I wouldn't be surprised if we could get that figured out. So I will look forward to working on this case with you. Take care.